Next, we have a couple of dynamic speakers as well. We have, should I have change? Sorry.
No, this.
Okay. First speaker will be Roger Chen. Hello, Roger. He's a consultant endocrinologist from University of Sydney, and we are very familiar with him. The next speaker will be Dr. Gerry Tan from Philippines, a consultant endocrinologist working out of Cebu City. And Roger will be talking about how to overcome the challenges of trying to intensify insulin regimens with perhaps a more simplistic regimen. And then Gerry will talk to us about clinical cases for which he, I suppose, did practical sort of trying to sort out the burden and the barriers that patients face. So without further ado, hello, Roger. Take it away.
Thank you very much, SP. I hope you can hear me. Lighting is a bit weird now that I look at it, but anyway, that's okay. It's wonderful to be invited again by Novo Nordisk to speak. So thank you to my dear colleagues from Middle East office and Malaysia and the region. And of course, it's great, even better to be in contact, sadly online, but hopefully in reality, in person with our friends and colleagues from around the region, from the Indian subcontinent, from Bangladesh, and also from Asia. These are my disclosures and disclaimers. Now, we've heard some very, very nice talks. Our chairperson spoke about the fact that diabetes is a progressive disease. So we know that a progressive disease needs progressive treatment, and we can't just start insulin and assume that people will be well controlled. We've also had Professor Prasad talking about metabolic memory, the importance of trying to get glycemic and metabolic control as good as possible early on. And we know that from UK PDS, etc. So in this first slide, I show you a very interesting study which looks at the consequences of delayed treatment intensification in patients with type 2 diabetes who've been fairly newly diagnosed, but without any previous cardiovascular disease. So this is a huge database from the United Kingdom. And what they look at on the black line, dotted line on top, is the patients with the HbA1c of more than 7% after 6 months of type 2 diabetes diagnosis, but these patients do not receive any form of intensification of treatment within 1 year of diagnosis. So that's the dotted darker line, and the y-axis has the HbA1c. And in the lighter blue line, in contrast, you have the patients with HbA1c of less than 7% after 6 months of type 2 diabetes, but these patients actually receive intensification of treatment within that first year of diagnosis. So in other words, you're comparing groups where they're just diagnosed and they may or may not be put on some treatment and they're left alone, as compared to the others where the HbA1c's achieved less than 7%, who actually achieve they receive, I should say, intensification of treatment early on. And you can see that the HbA1c is quite different. And what we call that difference may translate, in fact, to this so-called dysglycemic legacy, where, in fact, the differences between the two lines, that HbA1c combined with their blood pressure, etc., may increase the risk of complications. So the authors actually analyzed the data after 5 years, and they found that those who did not have treatment intensification had a higher risk of heart attack, hazard ratio 1.67, stroke 1.51, heart failure, a big topic in diabetes now, 1.64. And if we look at the composite of cardiovascular events, then an increased risk of 1.62 in that group. Again, emphasizing the need to really try to get control as good as possible early. Now, we know that besides basal insulin intensification being delayed, we also know that up to this basal insulin intensification occurring, that often there's 5-10 years where patients have lived with an HbA1c which is far above their target. And some of the studies from the US show that, in fact, patients may spend up to 5 years with an HbA1c of more than 9% before any insulin is introduced. So we have that delay already. But then they started on basal insulin. Unfortunately, that's not magic. And on the left side, there's a lovely study from the US showing that, in fact, 71% of patients who are started on basal insulin still have an HbA1c of more than 7% 2 years following that basal insulin initiation. So that's in the US. And on the right side, we have data, I think now from Scotland, where we look now at intensification of basal insulin being delayed and how frequent, or what is the rate at which the insulin regimen is changed over 3 years. So in the first column, you can see 60% have no switch or intensification. And unfortunately, there was no HbA1c at the actual change of treatment because it's not relevant. But 3 years later, then the HbA1c is still over 8%. In the second column, 19% are intensified with either prandial or premixed insulin, but they still have a slight drop in HbA1c, still better than perhaps before, but 9.2 versus 8.6%, but they're still not at target. And then finally, if you are changed over to a premix, then this was only 14% of the group. There's still 9.5% at the time of change, dropping down to 8.5. But clearly, it's not just a simple measure of starting basal insulin and continuing that. We have to reassess the patient. And what I do every time I see a patient is actually to make sure I've got them on the right regimen, that they're actually giving the insulin and they're actually able to understand, in fact, why they're giving the insulin and what the benefits are. So there is, I guess, a need to reassess all patients, but particularly those on basal insulin, and to work out whether they need any change in treatment for intensification. And Rupert's gone through some of this as well. Patients on basal insulin should be ideally reassessed at both a time limit and a dose limit. And as thought, for example, the time limit should be within a year. And I'll put it to you that perhaps even a little bit shorter than that, but it very much depends on the resources and I guess how often you're seeing the patient. And what I'll show you more is that there's a dose limit. There's this limit of 0.5 international units per kilogram weight per day of basal insulin, because I'll show you that beyond that, you may not get as much benefit as what you think you're going to get. In fact, you get very little benefit. There's less and less benefit above that unit per weight limit. So perhaps if the HbA1c is not achieved 3 months after initiating basal insulin, we also know that you're more than 3 times, there's 3 times more likelihood that these patients, in fact, still will not achieve the target HbA1c after 24 months. So that, 1 year may be the time limit, but really at 3 months, there's already a guide to whether we should be thinking of intensification of insulin. So again, this is the art of medicine. We really have to be aware of what the patients are, discuss this with them, and then change treatment if necessary. Now, this is the study I was alluding to from Ampere. It's a very, very nice study where it basically looks on the y-axis at the change in HbA1c per 0.1 international unit per kilogram increase in dose of insulin. So first of all, if you look at less than 0.3 international units per kilogram dose as the final insulin dose, and then 0.3 to 0.4, 0.4 to 0.5, etc., you can see that once you get into past 0.5, the actual potential improvement in HbA1c is getting a lot less. In fact, it plateaus above that 0.5 international unit per kilogram per day. So let's say if I'm 80 kilograms, if I'm on basal insulin, once I'm on about 40 units of that basal insulin, I really should be thinking of changing that dose or modifying that dose so that it includes some prandial insulin or premix, or in this case, a co-formulation. So the ADA, in fact, now recommends considering the addition of bolus insulin once basal insulin dose begins to approach 0.5 international units per kilogram per day. But Professor Prasad also has presented some lovely cases of where insulin Ryzodec is actually started, and we're certainly doing that a lot more in our institution because we just start the co-formulation and we can titrate that rather than switching from a basal, just another approach potentially to use. Rupert has gone through this, and we know that ultimately we can prescribe whatever insulin regimen that we want to. And yes, the basal bolus regimen may be the gold standard for many people, and it is suitable for many people who are able to carb count, adjust their their aspart or prandial insulin according to their carb intake, etc. But in fact, this is a very complex regimen, and there is a large percentage of our patients who actually can't cope with that. I've had some patients come up crying after they've been discharged from hospital saying, we cannot cope. We're on 2 injections of basal and 3 injections of prandial. We cannot do that. So, we have to think about the patient's perspective. Hypoglycemia, Rupa again has alluded to, and I'll show you something briefly there, but I won't go through that too much in detail. And again, poor treatment adherence. We have to ensure that we agree with the patient to use a regimen which is appropriate from them. So Rupa mentioned hypoglycemia. On the right side, what you can see is the internet survey, I think from Mark Perot again, looking at the attitudes of primary care physicians, but also diabetes specialists. And you can see that around 73% of physicians say that they would treat their patients more aggressively if there was no concern about hypoglycemia. So rightly or wrongly, certainly rightly in many situations, we are perhaps not as aggressive as we could be because we are worried about hypoglycemia occurring following or insulin therapy. And it's good that with these new insulins, particularly the co-formulations, that there is less insulin, there's less risk of hypoglycemia, as we'll show you, as compared to some of the other regimens. And on the left side of this graph, you can see that some patients decrease their insulin dose following a hypoglycemic event for both non-severe as well as severe episodes. Some of this might be very appropriate immediately after the hypoglycemic event or for a day after, but certainly it may not be appropriate, weeks and months after that particular event. This is just the last attitude survey looking at the patients and physicians identifying the larger number of frequent, the number of injections as a burden. Again, Rupert's gone through this, but if I can show you patient difficulties, I'm hoping you can see my mouse there. These are the attitudes of the patients and their physicians. And when you can look at the number of daily injections, in fact, both the physicians as well as the patients identify this as a major issue. Other issues identified, taking the insulin at a prescribed time of day, the injection time, adjusting the insulin dose, probably not as much, and there are other issues which patients also identify. We also have to remember, sadly, that not everyone actually uses their insulin. I'm still horrified sometimes when I have seen a patient. I remember 2 in the last 10 years, one whose wife brought all his insulin to me one day saying, look, he's never ever used it. We've gone through 5 years of consults. He's seen a dietitian, diabetes educator, seen his primary care physician, but he's actually never given himself an injection. And so that was a pretty devastating, lesson for me to really go through, what the patients want as well. On the other hand, with other patients telling us, look, my previous doctor said, just wind up the injection till, you can't turn it anymore and then give it after the meal. So, we have to remember again that a lot of the time patients may receive excellent diabetes education, but they forget what they're meant to do. So very important to ensure that we re-educate and the patients, virtually every visit. So in this multinational study, 1/3 of patients, in fact, were poorly adherent to insulin therapy, either missing doses or not giving them at all. And on the right side, again, you have a study from the United Kingdom. And in this case, again, up to 1/3 of patients self-reported poor adherence to insulin therapy. So we have at least very honest patients in many respects. So I'm going to take you through, what to do if you have a patient on basal insulin. Dr. Prasad and Rupa have already indicated that, in fact, Degludec, Aspart may be a very appropriate insulin to give in many situations where a patient requires insulin as the initial insulin. But here we have a whole lot of patients who are on basal insulin, and we then have to decide how we intensify. So in this particular study, 500 patients were recruited, all with type 2 diabetes. They were then randomized, they had type 2 diabetes, and they all had been on some form of basal insulin regimen for at least 90 days prior to screening, and they could continue their oral anti-hyperglycemic therapy. HbA1c between 7 to 10%. So the usual criteria. They're randomized into two groups. First of all, the top group are those who receive Ryzodec or IDEC-ASP once a day, and they continue their oral agents. Now, in this case, the IDEC-ASP can be given at the main meal, either whichever the main meal is, and that's the discretion of the investigators and the patient. The second group receive or continue to receive their basal insulin now in the form of glargine, but they now have one injection of aspart at the main meal of the day. So if you like, the basal plus regimen. The glargine is given according to labels, so it could be morning or night, and the aspart is at the largest meal. So this phase of the study continues for 26 weeks. So you're either on IDEC-ASP or you're on glargine plus one injection of aspart for that 26-week period. Now, at 26 weeks, if the HbA1c in either group or patient is more than 7%, then those who are on one injection of IDEC-ASP can be intensified to 2 injections of IDEC-ASP. That again happens at 32 weeks, and then that goes to the rest of the study. So at the end of the study, patients are either on 1 or 2 injections of IDEC-ASP or Ryzodec. Now, in the glargine group at 26 weeks, if the HbA1c is still more than 7%, then the glargine plus aspart group can be intensified to glargine plus aspart and another shot of aspart, so 2 shots of aspart. And again, that can change at 32 weeks. So by the end of the study, the patients could be on 1 injection of glargine universally, but they're either on 1, 2, or 3 injections of aspart by that 38-week end of the study. Now, what are the results? And intuitively, you would think that there's no way that, a group who receive 2 injections or 1 injections a day, and you can see that here, would achieve equivalent control. But on the left side, here you see the basal to basal bolus therapy, and patients are on up to 4 injections a day. And on the right side is the cartoon or depiction of what happens in the Ryzodec group. And in fact, they are on a maximum of 2 injections a day. And it's I guess intuitively, you would still think that those on basal bolus would still do better than those on twice-a-day Ryzodec. But as you can see, I'll take you through this slide. There's no difference in HbA1c. That's on the top left-hand side of that graph. No difference in HbA1c at any point in the study. And fasting plasma glucose also improves. And there's no difference between the groups at the end of the study as well. If we then look at confirmed hypoglycemia, something we've been speaking about as being one of the barriers for patient initiation and success to achieve glycemic control, you can see that, in fact, overall hypoglycemia is less in the Ryzodec or IDEC-ASP group. It's not statistically significant, but it's numerically less. But what is most significant, in fact, is the decrease in nocturnal confirmed hypoglycemia, which is hypoglycemia which occurs between about midnight and 6 o'clock in the morning. And that is reduced very significantly at all phases of the study till 38 weeks. So again, you would think, okay, fine. But remember, we're dealing with basal bolus, the gold standard basal bolus, as compared to IDEC-ASP used once or twice a day. And when I think about this study, I think it's very impressive that, first of all, the HbA1cs are similar. Look, it is a treat-to-target study, so it's certainly possible. But the rates of hypoglycemia are less in the Ryzodec group. So there's absolutely no disadvantage here in using IDEC-ASP or Ryzodec once or twice a day as compared to a basal bolus regimen in a group of individuals who are usually very, very keen. They're enrolled into a clinical study. Very nice and interesting results indeed. The total insulin dose, as Rupert also mentioned, is less in the Ryzodec group. And the end of the study, the glargine or the basal plus group, 89.3 units, and in the Ryzodec or IDEC-ASP group, 83.4 units. Much of that difference is due to, I think, less of the prandial insulin, if I remember. And again, just a cartoon. On the left side, we're basal bolus. So we have, 7, 14, 21 injections of prandial insulin a week, plus another 7 basal insulin shots. Okay, that's a lot of injections, 28 needles a week, and more blood glucose monitoring required. In the IDEC-ASP twice-a-day group, it's the maximum of 2 injections a day, and therefore 14 per week altogether. So that's a lot less than what we're talking about in the basal bolus group. So to conclude, just to recall this very interesting step-by-step intensification study. So in those already on basal insulin, you have 2 options. And using IDEC-ASP, in fact, confers absolutely no disadvantage. There's non-inferiority confirmed. The total insulin daily dose, or the total daily insulin dose, in fact, is lower in the IDEC-ASP group. The confirmed hypoglycemia is 10 weeks lower at week 26 and 14% lower at week 38, but it's not statistically significant. But it's the nocturnal confirmed hypoglycemia, and this is the glycemia or the hypoglycemia that we really fear. Is the dangerous hypoglycemia, and this is 45% less at week 26 and 39% less at week 38 in the Ryzodec or IDEC-ASP group, and that's statistically significant. So again, just to conclude, we're comparing gold standard with 1 to 2 injections of Ryzodec or IDEC-ASP co-formulation a day, and I think, again, when I think about this study more and more, it's very, very impressive that 1 to 2 injections of this co-formulation can lead to equivalent glycemic control, but with less hypoglycemia. With that, I thank you.
Okay, thank you, Roger, for that nice introduction to my real-world scenario in terms of case presentation. I am Dr. Gerry Tan, and again, thank you, SP, for that nice introduction a while ago. So these are my disclosures. So what I'm going to do today is to discuss with you some real-world case scenarios that I've seen in my clinic. First will be a patient whom I intensified using IDEC-ASP from basal insulin. And second case is a patient whom I switched from multiple daily insulin regimen to twice-a-day IDEC-ASP. So let me introduce to you Mr. Ramos, who is a 62-year-old bank manager who is diagnosed diabetic since 2009. He is presently unhappy because his blood glucose remains uncontrolled, with an A1C of around 9.5% on the present medications, which include basal insulin glargine of 28 units every 9 p.m. And this is in combination with a DPP-4 and metformin twice a day. Mr. Ramos, as an international bank manager, travels a lot and different time zones. He's very irregular daytime meals, but he claims to have a very heavy lunch. And like any Filipino, he loves noodles and pastries rich in carbohydrates, and I think this is very common among Asian counterparts as well. He claims to be compliant to medications, but again, if you look at his lifestyle, he is sedentary and he has a very disturbed sleep-wake cycle. So he came to me because he wants better control of his glucose, and he also claims that on his present basal insulin, he hates the usual lows in the mid-morning. So the next question is, what's next for our patient, Mr. Ramos? If you know that when we try to target the glycemic target and trying to lower the A1C, we know that it's a combination of 2 glucose. It's the fasting and the postprandial blood glucose. But we know even if our patient is well controlled based on an A1C of less than 7, nearly 40% of our patients categorized in good control have significant glucose variability. And this is significantly contributed by postprandial hyperglycemia. And it is very critical to realize that if you look at glycemic control, postprandial blood glucose contributes significantly early in the course of the disease when the fasting glucose levels are near normal. Clinically, therefore, if you look closely at a patient whose A1C is less than 8% and you want to put this patient at goal to less than 7, then it is best achieved by specifically targeting your postprandial glucose levels. However, if the patient's glucose continues to deteriorate and in A1C continues to rise, this time the contribution of the fasting plasma glucose becomes more significant. Clinically, therefore, if you have a group of patients like Mr. Ramos, whose A1C is now more than 9%, fasting plasma glucose progressively is increased. At this time, both fasting and postprandial glucose are important at these higher A1C levels if you want to target A1C to below 7%. Furthermore, if you look at plasma glucose homeostasis in terms of the complex network affecting your postprandial blood glucose, one of the issues a lot of primary care physicians always miss is the meal size and the meal content. Meaning, before you even subject your patients to any pharmacotherapy, it is very critical that you look at medical nutrition and lifestyle. And this is my point at this point. Meaning, if you look at the glucose concentration 24 hours, you can clearly see the peaks after each meal, suggesting that glucose variability is really affected by food. In fact, post-meal glucose responses have been shown to be influenced by both the quality and quantity of carbohydrates contained in the meal. Now, this is typical Filipino food that Mr. Ramos takes, rich in carbohydrates, which may result in high postprandial glucose levels. This is the traditional Asian diet. In fact, in one unpublished survey that I did among my patients, they even go up to 70% of their macronutrient composition coming from carbohydrates. Obviously, therefore, if you don't target their medical nutrition therapy, then these high glucose loads will lead to higher prandial glycemic excursion. Thereby, if you look at blood glucose concentration, carbohydrates account for 90% of the total variability in blood glucose levels. So I always take time to counsel my patients about carbohydrate distribution to help my medications work, whether I'm talking about oral medications or I'm talking about insulin. So for Mr. Ramos, therefore, just like what Roger was saying, before we offer any medical treatment, then it is very critical that non-medical approach should be addressed, address the medical nutrition of the patient needs, educate regarding lifestyle measures, and of course, inform him that his sleep-wake cycle, which is pretty disturbed, will also affect control his blood glucose. So when we look at patient, right, Mr. Ramos, and look at his basal insulin, we clearly see that it has not been well controlled. Clearly, with his lifestyle, purely basal insulin will not be sufficient for him because adding basal insulin to his regimen only lowered his basal hyperglycemia, and there was none to address the postprandial peaks. If you look at the slide that was presented by Dr. Rupa from the ADA 2021, clearly when they looked at intensifying to injectable therapies, after GLP-1, you can either start this patient on a basal insulin. They recommend starting at 0.1 to 0.2 international units per kilo. But if you look closely at Mr. Ramos' dose of glargine at 28 units, he already has reached what we call as over-basalization of the insulin therapy, as Roger was saying. Meaning, there are clear signals on Mr. Ramos that you cannot further increase his basal insulin because he has reached the dose of 0.5 international units per kilo. Other clinical signals that you can see whether you have over-basalized the patient is when there's a high bedtime to morning differential or a high post-meal to pre-prandial differential. In this case, therefore, it should prompt you to reevaluate to further individualize therapy. So for Mr. Ramos, therefore, My plan was to advance therapy and to add prandial insulin. You've heard the advantages and disadvantages of premix, including the multiple daily insulin regimen. So for Mr. Ramos, who was on glargine at 28 units with peak postprandial glucose above 200s, he therefore really needs insulin intensification. So if I intensify insulin in this case, I do a simpler effective intensification. Yes, basal bolus regimen is a very physiologic, it's the gold standard. I use it a lot, but you need separate injections and you need 3 to 4 times a day of injections. If we can give this patient a combination of basal and bolus insulin in one pen, then this will be as a way for us to simplify the intensification of Mr. Ramos. So the barriers of insulin intensification, for example, where patients really feel overwhelmed because of the too many injections that they have to get, plus the providers thinking about how to introduce insulin, how to introduce or convince them for multiple daily insulin regimen. One way definitely to address these barriers is the use of this co-formulation called IDEG-ASP. So IDEG-ASP is for me the ideal way to intensify. Ropa has also showed this slide. In fact, this is a very unique co-formulation because the insulins, both of them, do not interact in solution and in the subcutaneous tissue, therefore retaining their individual properties. With this once-a-day IDEG-ASP, I can therefore intensify Mr. Ramos' regimen from a once-a-day basal to a once-a-day IDEG-ASP in one injection. So for Mr. Ramos, who has heavy lunch, he now tries to sleep well, he now corrects the way he eats. I actually am a fan of a meal replacement for my Filipino snacks because we love to eat heavy snacks in terms of carbohydrate load. So with meal replacement and switching to IDEG-ASP, I was able to convince him that this is not intensifying with more injections, but similarly only one injection. So when I switch Mr. Ramos from basal or any patient from basal insulin, first I determine when is the patient's biggest meal. What is recommended is a starting dose of 60 to 70% of the total daily insulin requirements, some 80%. I usually don't do this in the case of Mr. Ramos because his A1C is already 9.5%. So I'm going to switch based on a basal insulin in a 1:1 ratio. So Mr. Ramos is computed based on the following. His biggest meal is lunch. His present dose is 28 units of glargine. If I give him 40 units of IDEG-ASP, which has 70% of it is Degludec, then I'm giving a 1:1 ratio for the basal insulin. In one injection of 40 units, I'm giving the patient 12 units of Aspart. So giving IDEG-ASP of 40 units to Mr. Ramos before lunch, I also continued his DPP-4 inhibitor and metformin. Coupled with medical nutrition therapy and lifestyle, now he exercises at least 10 to 20 minutes per day, which is better than being sedentary. We were able to reduce glycemic variability significantly. And with the regimen, his A1C dropped from 9.5 to 7.5% in 8 weeks. So here is a simple case of insulin intensification where I did not add an additional injection. My second case is a patient whom I switched from multiple daily insulin regimen to twice-a-day IDEG-ASP. Mr. K, who is a businessman, actually was started on a multiple daily insulin regimen approximately 6 months prior to seeing me. His A1C upon seeing me was 8.5%. He was really compliant with the multiple daily insulin regimen for the first 4 months. He was on glargine of 30 units and glulicine of 8, 6, 10. But he claims after 4 months, he got tired of the multiple injections, and then he now misses lunch or occasionally dinner insulin due to work. And he complains that these multiple injections is now becoming burdensome. And it's true, because if you look at the issue of basal bolus regimen, it's the complexity that is a barrier. Complex in terms of monitoring and complex in terms of titration, and again, multiple injections. If you look at the attitudes of diabetics toward injectable therapy, all patients, approximately 42%, will be troubled by the idea that you're going to give him more injections. If you look at the subcategory of patients who have high anxiety about injections, majority of them are troubled by the idea that you're going to give them more injections. So for Mr. K, therefore, his attitude that he already tries to miss lunch or dinner insulin because of too many injections, his attitude toward frequent injections and poor compliance, now is a time for us to resort to simpler intensification. So this is where I switch Mr. K from multiple daily insulin regimen to IDEC-ASP twice a day. And this is how I do it. First, I determine the patient's 2 biggest meals. I then compute for the basal insulin initially. Then divide the total dose into equal 2 separate injections. He is on glargine of 30 units daily with breakfast and dinner as 2 biggest meals. If I give Mr. K IDEC-ASP 44 units, 70% of 44 is 30 units Degludec. So that's a 1:1 switch on basal insulin. And with this dose, I have 13 units of Aspart. I then split 44 into 50-50%, give 50% for breakfast, which is the biggest meal, and another 50% before dinner, second biggest meal. On IDEC-ASP, 22 units before breakfast and 22 units before dinner, of course, Mr. K was happier because instead of 4 injections, now we resolved the issue to twice a day injection. Titration was based on an individualized target. I usually want it to be 80 to 120. I add 2 if above target. I minus 2 if below target. And this titration is based on the dose adjustment on the lowest of the 3 preceding fasting plasma glucose measurements. Again, it should be individualized depending, some 70 to 140. And of course, do not increase the dose if you have hypoglycemia. Very important is don't confuse yourself with the prandial. Just compute for the basal, because postprandial blood glucose with IDEC-ASP will just follow with the improvement of your fasting blood glucose. You can either do once or twice weekly titration depending on your trust on your patient to titrate the dose. So for Mr. K, you can clearly see that due to better compliance and of course better medical nutrition therapy, we were able to reduce significant glycemic variability specifically for the post-breakfast and post-dinner peaks of blood glucose. And with better compliance, due to lesser injections, we were successfully able to reduce his A1C in 8 weeks to 7.2%, with no risk of hypoglycemia, and Mr. K is a happy person. There may be some questions as to how we can adjust the dose based on fasting and postprandial, but here's my personal and practical practice pearl for all. It is best that you compute for the basal needs of the patient first to control the overall glycemia. The Aspart dose for me is just a bonus to help lower the prandial surge. If you're questioning that Rupa was saying, here's the insulin Degludec that has 24 to 32 are an ultra-long acting insulin. If I give IDEG-ASP twice a day, will there be no accumulation of insulin? Will there be no stocking? Actually, no. Because once the steady state of IDEG-ASP is achieved, specifically the Degludec, the exposure level of insulin Degludec is unchanged from day to day. If you give it twice a day, the plateau levels of exposure and effect depend only on the total insulin dose rather than on the dosing frequency. The twice a day frequency only influences the peak to trough ratio. And as long as the total insulin dose is the same, whether you give it once a day or twice a day at steady state, your patient will be safe because the IDEG-ASP will give your patient the same total glucose lowering effect over the day. With that, thank you very much.
Thank you very much, Gerry. That was excellent, very clear presentation of your two complex patients and how you managed to gain their support and confidence. So without further ado, we are going to move on